Okay. So, how are you, Nupur?
Fine, ma'am. How are you? Yesterday,
Yeah,
ma'am, I fell
alhamdulillah.
asleep. It
Yeah,
was
yeah,
very
it must
late,
be
so
late
I
at
fell
you.
asleep.
Yeah, it was very, yeah, it must be very late. Yeah, the time differences. And now the winter has started, so 1 hour more differences there.
Yes, ma'am.
Yeah. So we'll start. Everyone will join in between because Sadaf said she will be joining in between. I don't know about others.
Yes, yes, ma'am.
Okay, okay.
Ma'am,
So we are going to start.
embryo,
Yeah.
ma'am, embryo
Yes.
discussion
Yes.
is also left with that question
Yes.
and
Yeah. Yeah.
answer
Yeah. It's remaining. Yes. We are. Yeah. We have to discuss that. Yeah.
sometime.
Definitely.
Ma'am,
I also remember.
today's lecture will be
Hmm.
long or it is short?
Yeah. It's not too long. No. No. It's
Okay,
normal.
okay,
Yeah.
okay,
Two
ma'am.
and a half hours going to be. Okay.
Okay, ma'am.
Okay.
Yes, ma'am. Yes.
Okay. Mhm. So we are going to start with the physiology of respiration. So coming to the first to the what are the lung volume and the capacities of them. So the first that we should know is the tidal volume. So tidal volume you will see it is written like as capital B and the T will be written in the short form. So it is the volume which is inspired or expired with each normal breath. That is called as tidal volume. And what is inspiratory reserve volume? It is the volume that can be inspired over and above the tidal volume. So normally the tidal volume we take is its normal value as 500 ml. This is the normal tidal volume. So whenever if the person is breathing more than that, that will be the inspired volume of air. Now expiratory reserve volume. Now this inspiratory reserve volume it is used during exercise because the person has to breathe more. That is why it is used more in cases of um, it is used in more cases of an exercise. And expiratory reserve volume, it is the volume which can be expired after the expiration of a tidal volume. So whenever we breathe normally, we are inhaling or exhaling the tidal volume. If you are doing some stress work or some more energy, more breathing is required, then it is going to be either the inspiratory reserve volume if you are breathing inside, and if you are expiring out, so if you are exhaling it out, it will be expiratory reserve volume. Then we have the term that is called as the residual volume. So it is the volume of air which remains in the lung even after maximal expiration. This residual volume it cannot be measured by spirometry. Because why it cannot be measured by spirometry? Because it is the volume. If this volume is also out of the lungs, then the lungs will collapse. That is why every time the lungs has to have some of the air inside it. That is called as a residual volume. Now, what is the dead space? There are two dead spaces. The first one is the anatomical dead space, and another one is the physiological dead space. So, anatomical dead space is means that it is the volume of the conducting airways. It means the whole of the trachea, the bronchioles, and the lungs. This is the space we call the dead space. It is the functional measurement. It is the as the volume of lungs that doesn't participate in the gas exchange. That is the third pore of the lungs that is the whole of respiratory
Ma'am,
tract.
voice is cracking.
Now also is okay now.
No, ma'am, it's still cracking.
Can you hear my voice?
Yes, ma'am.
Yes. Okay. Okay. I'll just start sharing the screen.
Ma'am, no volume.
Okay, now can you hear me?
Yes, ma'am.
Okay, okay. So yeah, I was speaking and speaking. I thought okay, I'll starting. So in what is dead space? The dead space, these are of two types. That is the anatomical dead space, and we have the physiological dead space. And we have the physiological dead space. So anatomical dead space, it involves the whole of the volume of the conducting airways, and its normal value is approximately 150 ml. While the physiological dead space, it is the volume of lungs in which there is no exchange of gas exchange. There's no involvement of gas exchanging takes place, and it is normally approximately equal to the anatomical dead space. But sometimes this physiological dead space, its value can be greater than the anatomical dead space, in which cases in which there is going to be some abnormality in the lungs, or there is any pathology of the lungs in which there are ventilation and perfusion defects. So how do we calculate the physiological dead space? So D small the D you can see here, it is the physiological dead space, and T is the tidal volume, that is normal value is 500 ml. And this is the pressure of carbon dioxide in the A stands for alveolar gas. So this is the partial pressure of carbon dioxide in the alveolar gas, and this is the E stands for the expiration or the expiratory air. So it is the partial pressure of gas, carbon dioxide in the expired air, and it is divided by the partial pressure of carbon dioxide in the alveolar. So this is how we calculate the physiological dead space. That is the physiological dead space. It is equal to tidal volume multiplied by the amount of pressure of carbon dioxide in the alveolar gas minus the amount of carbon dioxide in the expired air divided by the amount of carbon dioxide in the alveolar air. So we have to, it is the similar, that is the amount of carbon dioxide in the alveolar gas as well as the amount of carbon dioxide. um, it is this value in the top part also and in the denominator, and the only different thing is that the amount of carbon dioxide in the expired air. So now you can see here, now this graph, it is asked in the exam. So the graph is made, only the graph is there, and they mark any of the points, and they ask in the exam that which point represent which. So you should be knowing that this amount of volume, the normal breathing which we are having breathing, that is the tidal volume. And when we breathe above the tidal volume, it is called as the inspiratory reserve volume. When we are breathing beyond the when we are expiring beyond the tidal volume, then it is called as the expiratory reserve volume. And residual volume, we can see here from the expiratory reserve volume, the below part, it is the residual volume, which is the amount of air which you will find always in the air, because always in the lungs, because if it is not present, what will happen, the lungs may get collapsed. And if we combine, now you can see here, if I combine the tidal volume and the inspiratory reserve volume, it is called as the inspiratory capacity. And the functional residual capacity, it is when I add the residual volume and the expiratory reserve volume, then it is called as the functional residual capacity of the lung. So capacity, if we look at the capacity, it is addition of two volumes. Either it is going to be tidal volume and the inspiratory reserve volume to give us the inspiratory capacity, and in terms of functional residual capacity, it is calculated by the expiratory residual reserve volume and the residual volume. They together form the functional residual capacity. Yes. Now, what is ventilation rate? Now, the rate of ventilation, there are two rates of ventilation. One is the minute ventilation and another one is alveolar ventilation. Alveolar ventilation, it itself indicates that it is the ventilation of alveoli. So minute ventilation, how it is calculated? It is calculated by the tidal volume and the number of breaths. So normally the tidal volume is 500 ml, and the respiratory, the number of breaths that we take is the normal respiratory rate is 15 to 20. It is considered as a normal. So if we multiply 15 by 15, so this value will be the minute ventilation, normal minute ventilation. And the alveolar ventilation, it is expressed as the tidal volume minus the physiological dead space. VD stands for the physiological dead space. So if we minus this volume, the remaining volume will be the physiological dead space. So tidal volume minus physiological dead space into breaths per minute. So this will calculate us about the alveolar ventilation. And if we multiply the tidal volume into breaths, so it will be only it will only be minute ventilation. So this is the only difference you can see in between the minute and the alveolar ventilation. Now, what is inspiratory capacity? It is the sum of tidal volume and the inspiratory reserve volume. And what is functional residual capacity? It is the sum of expiratory reserve volume and the residual volume. It is the volume of air remaining in the lungs after the tidal volume is expired. It includes the residual volume. So whenever there is going to be residual volume, you cannot measure that you cannot measure the amount of air in the respiratory cavity. That will be because it cannot be measured by the spirometry. You need to remember this thing, because in the questions they have asked in the exam that which of the capacity or which of the volume from the lungs cannot be measured from spirometry. So it will either be in terms of volume, it is going to be the residual volume, and in terms of capacity, it is going to be functional residual capacity. Now, what is vital capacity? It is the sum of tidal volume, the inspiratory, and the expiratory reserve volume. So all of them, when we combine three of them together, the tidal volume, the inspiratory, and the expiratory reserve volume, it is called as the vital capacity. Now, the vital capacity, it is the volume of air that can be forcibly expired after a maximal inspiration. So when we take a deep breath and when we expire that air outside, that will be called as the vital capacity. And what is total lung capacity? It is the sum of all the lung four volumes. So what did the four volumes we studied? We studied the four volumes as tidal volume, the inspiratory reserve volume, the expiratory reserve volume, and the residual volume. So when we add these four values together, so it will give us the total capacity of the lung. It is the volume in the lungs after a maximal inspiration. As it also involves the residual volume, so this value, this total lung capacity, it also cannot be measured by spirometry. So in terms of volume, only the residual volume will not be measured by spirometry, while in terms of capacity, the functional residual capacity and the total lung capacity, it cannot be measured with the help of the spirometry. Now, what is forced expiratory volume? So expiratory volume, it itself indicates that expiration volume, that the air that is expired, but it is forcefully that is expired. So the forced expiratory volume is the volume of air that expired in the first second of the forced maximal expiration. So when a person is breathing very hard because of if she is doing any exercise or any is because of any stress, when she is breathing, when she is expiring the air out, so in the first air that comes out will be called a forced expiratory volume. Now this forced expiratory volume, it is normally 80% of the force vital capacity, and the normal volume of forced expiratory volume, it is 0.8, and it is calculated by forced expiratory volume divided by forced vital capacity. Now, we have two types of lung disease. One we have the obstructive lung disease, another we have the restrictive lung disease. So in cases of obstructive lung disease, what happens like asthma and COPD, that is chronic obstructive pulmonary disease, both the FE1, that is the forced expiratory volume, and the forced vital capacity, they both are reduced. But FE1, but the forced expiratory volume, it is reduced more than the forced vital. Both the values are decreased, so the volume of the resultant answer will be the decrease in the forced expiratory volume to the forced vital capacity in case of obstruction, like in case of asthma and COPD. Now, but if we talk about in terms of restrictive lung disease, such as the fibrosis, in this condition, what happens? The forced expiratory and the forced vital capacity, they are reduced. But in FE1, the forced expiratory volume, it is reduced less than the forced vital capacity. So in has total value is decreased. In case of obstructive and restrictive, the difference is that if in sorry, Nupur, I can't see your message. Is it okay, voice?
Ma'am, your voice. Yes, ma'am, the voice is cracking.
Okay, okay. Now is it because the mic it got away from me?
Ma'am, it's
So in
better, but
terms of obstructive and
yeah.
restrictive, it is cracking. Okay.
Ma'am, it's still cracking.
Is it better my voice, Nupur?
Yes, ma'am.
Okay. Yeah, I'll just ask them to share. Allow me to share. जी. Okay, so now you can see here, this is the normal in which the forced expiratory volume and the forced vital capacity, they are there. But in case of obstructive lung disease, there is decrease in both the volumes of forced expiratory volume and the forced vital capacity. You can see here, there is a decrease. If we talk about restrictive lung disease, in that what happens, there is a decrease. So that is why in the value, if we see in cases of restrictive conditions, the value it is increased. That is the value when we divide both of them. That is the force expiratory volume divided the force vital capacity. But in cases of obstructive, the value is in total the value is decreased. So Nupur, will you summarize for me till here? The volumes and
Yes,
the
ma'am.
capacity of the lungs. Oh.
Yes, ma'am.
Hmm.
Ma'am, in uh, the tidal volume is the volume that we respirate in every minute.
Hmm.
Uh, then the dead space.
Hmm.
The dead space is the space. It is of two types: anatomical and physiological. Anatomical dead space is the space that the no exchange. Uh, the no exchange of gas is taking place because of anatomical structures, that is trachea and bronchioles. And physiological dead space is the space where no exchange of oxygen is taking place because of no exchange of oxygen is taking place. And
Yeah,
then
oxygen, carbon dioxide, both will not
yeah
take place.
no exchange of gases is taking place. Now
Yeah, gas is taking place.
physiological dead space is calculated by a formula, but that is tidal volume into the partial pressure of no, sorry, tidal volume into the PCO2 of alveolar gas, that is partial pressure of carbon dioxide in alveolus minus the partial pressure of carbon dioxide in expirated air upon the partial pressure of carbon dioxide in alveolar gas.
Hmm.
Then
Then
the
other
various
inspiratory
capacity.
reserve volume.
Yes, ma'am.
Hmm.
The inspiratory reserve volume is the volume that we can we can inspire more over tidal volume. The expiratory reserve volume is the volume of air that we can
Hmm.
expire more over the tidal volume. And the residual volume is the amount of gas that always
Hmm.
remains in the lungs that cannot be expired. Then capacities are a
Hmm.
combination of these volumes, individual volumes. The
Hmm.
forced inspiratory capacity is tidal volume plus no, sorry, inspiratory capacity is the tidal volume plus the inspiratory reserve volume. And the
Yes.
functional residual volume is the residual volume plus the expiratory reserve volume. Then the vital capacity is the amount of air that we can expire
Hmm.
forcefully after no, the amount of air that we can expire after for after forceful
The
inspiration.
normal.
So
Yes,
that
after forceful. So that
so
is
that
called
is
as the
inspiratory reserve
hmm. That
vital
is
capacity.
inspiratory. Yeah, inspiratory
So it is
capacity.
inspiratory reserve inspiratory reserve volume plus tidal volume and this inspiratory reserve volume plus tidal
The
volume. And
volume
ma'am,
gas.
ma'am
Expiration.
is okay, forced vital capacity and reserve volume.
Yes, all the three you will
So
plus
it is
tidal.
it's just the yeah okay yeah the inspiratory reserve volume, tidal volume, and expiratory reserve volume. It is the amount of air that can be forcefully expired after a maximum inspiration. Okay. And total
Hmm.
lung capacity is sum
Yes.
of all the four values, that is inspiratory
Yes.
reserve volume, tidal volume, expiratory reserve volume, and residual volume.
Yes.
Then whenever we cannot measure
Then
residual
what is
volume by
force?
spirometry, so all
Hmm.
those volumes
Yes.
and capacity that include residual volume cannot be measured by spirometry. So there are three, that is residual volume itself, then
Hmm.
functional residual capacity, and total lung volume. total lung capacity. Sorry,
Hmm.
total lung capacity. So
Total lung
these three cannot be measured by spirometry.
will not be measured.
Yes.
And what is minute and alveolar ventilation?
Oh yeah, minute value ventilation is the amount of air that goes into the lung in every minute. That is tidal volume into the ventilation rate. That is respiratory rate. So
Respiratory rate. Hmm.
the
Sorry, no,
uh,
I can't. Yeah. Yes, yes.
the alveolar volume, the
Hmm.
alveolar ventilation is the tidal volume minus the ventilator, the physiological dead space
Dead space.
into the
Hmm.
respiratory rate.
Into the respiratory rate. Yes. And what is forced expiratory volume?
Hello?
Yes. What is forced expiratory volume?
Yes, ma'am. Force expiratory volume is the amount of air that is expired forcefully in first second of forceful expiration. So usually 80% of the air is expired in the first second. That is forced expiratory volume upon a forced vital capacity is equal to zero point 0.8.
Hmm.
And in obstructive diseases, both decrease force expiratory volume and force vital capacity both decrease but the reduction in forced expiratory volume is more than the reduction in forced vital capacity. Therefore the net effect is a reduction in the forced in forced expiratory volume. And uh, in restrictive disease,
Hmm.
the both still again decrease, but the decrease in the forced vital capacity is more than that of forced expiratory reserve volume.
Hmm.
Therefore the ratio increases.
Yes. Therefore, the ratio increases. Yeah. So these definitions you will have to learn by heart. There's no other choice because in the exam they only give you the definition and they ask you like which volume is it, or they give you this diagram like tell us that which what is this label this that it is given as A. So what does A stands for? They ask you what does B stands for, what does C stands for. So you will have to know this diagram.
Yes, ma'am. And
Uh,
ma'am, the ratio
hmm.
of forced expiratory volume in 1 second by forced vital capacity, does it have any name, ma'am? Is it called something? Yeah,
No,
this ratio point 0.8.
no,
It
this is
does not.
called as an no, it is called as the force expiratory volume, that is 0.8 in total.
Okay. Okay.
Yeah.
Okay, ma'am. Yes.
Okay. So now, in terms of normal value, the normal value of tidal volume will be 500 ml, and the inspiratory reserve volume, the total value will be 500 ml plus the remaining volume. So it becomes in total 3000 ml, and the total value of expiratory reserve volume it is 1100 ml, and the amount of air which will always remain in our lungs, that is 1500 ml, that is the residual volume. And if we talk about inspiratory reserve volume, that is the tidal volume plus the inspiratory reserve volume. So tidal volume is 500 ml and the inspiratory reserve volume is 1500. So when we add both of them, it becomes 3500 ml. And the function residual capacity, the total value is 2300 ml. The total vital capacity, it is 4600 ml, that you need to remember. And also the total lung capacity, when we add all the volumes together, the total capacity of the lung, it is 5800 ml. or we can say it as 5.8 liters. So now coming to the how does the breathing takes place? For the breathing, we need diaphragm, that is the most important muscle, and we have another accessory muscles that are the external intercostal muscles and the accessory muscles. So diaphragm, it is the most important muscle for inspiration. When the diaphragm it contracts, the abdominal contents they are pushed downward, and the ribs will move upward and outward, increasing the volume of the thoracic cavity. So you need to remember this thing that when the diaphragm is pushed down, so abdominal contents are also pushed down, but the ribs they will move up and outward. But when the diaphragm it goes up, the abdominal content will also go up, but the ribs they will be downward and inward. So decreasing the volume of the thoracic cavity. The opposite of it will take place in cases of expiration, the total opposite of inspiration. And these accessory muscles and the external intercostal muscles, they are not used for inspiration during the normal quiet breathing. They are used only during exercise and in cases of respiratory distress. And the muscles of expiration, the expiration, it is normally a passive process because the lung and the chest wall system it is elastic. It returns to its resting position after inspiration. So inspiration normally is a passive process. Now the expiratory muscles which are used during exercise or when the airway resistance is increased because of the disease, that is the asthma or any during exercise, strenuous exercise. And when we do, and when does the person uses the abdominal muscles? So what happens when the abdominal muscles are used? It compresses the cavity, the diaphragm will go up and it will push the air out of the lungs. That means the expiration is taking place. And the function of the expiratory muscles is to pull the ribs downward and inward in cases of expiration. But in cases of inspiration, the ribs, they will go upward and outward. So just for easy remembrance, you can only remember one thing, either the inspiration or the expiration, and the other one will be the opposite of it, total opposite. Now, what is the compliance of the respiratory system? Like we have the compliance of the cardiovascular system, we also have the compliance of the respiratory system. That is because it is analogous to the capacitance in the cardiovascular. Is also the same. That is C equals to compliance, V equals to volume, and P is the pressure. So when the device is operating, the pressure it is evaluated completely live means the compliance of the respiratory system it is directly proportional to the volume, but it is inversely जी सामने शेयर कर ओके जी जी
Dr. Aqsa, you can share the screen
Yeah,
now.
okay, thank you. So the compliance, it is directly proportional to the volume, and it is inversely proportional to the pressure of the pressure. So it is inversely related to the stiffness, and it is the slope of the pressure volume curve. It is the change in volume for a given change in the pressure. The pressure can refer to the pressure inside the lung and also the airways. That is, it can be the pressure of the bronchioles, the alveoli, or it can be the transpulmonary pressure. That is the pressure difference across the pulmonary structures. So any pressure it could be, but it will be any volume. The any volume will be given and any value of the pressure will be given. So you will be able to calculate how much the compliance of the respiratory system means, that how much the lungs and the chest wall they can expand when they are filled with lungs. So this is called. Now, how do we calculate the transmural pressure? The transmural pressure, it is the alveolar pressure minus the intrapleural pressure. So I can simply write TP, that is transmural, sorry, the TM, that is the transmural pressure. It is equal to alveolar pressure minus the intrapleural pressure. So when the pressure outside the lungs, that is the intrapleural pressure, it is pressure outside the lung, it is negative, the lungs will expand and the lung volume will increase. So when so if these are the two lungs and the pressure outside the lungs, it is negative. So what will happen, that the lungs, they will start to expand. So because the air can go now inside it easily. But when the pressure it becomes positive, so what will happen? The lungs, they will start to squeeze, or become they will not be able, now they'll be able to exhale the air. The air will come out of the lungs instead of going into the lungs. So this is the thing that you need to understand. Then when the pressure outside the lungs it is negative, then the lungs they will expand and the volume inside the lungs it will increase. While when the pressure that is becomes positive, lungs will collapse because they're causing the air to be expired out of the lungs. Lung volume will always increase, but the remaining residual volume which will always be present, which is the normal value is 1200 ml. So inflation of the lungs, the inspiration, it follows a different curve than the deflation of the lung. And the difference between the inspiration and the expiration, it is called as hysteresis. And it is due, and it is due, and the difference between the inspiration and the expiration, it is called as hysteresis, and it is due to the need to overcome the surface tension when inflating the lungs. In the middle where the pressure, the compliance is greatest and lungs are most distensible. When the expanding pressure it becomes high, the compliance it gets lowest and the lungs they are least distensible, and the curve it flattens. So when the pressure so when the outside pressure, when the pressure outside the lung it is negative, the lungs they expand and the lung volume it increases. While when the pressure inside the when the pressure outside the lung it is positive, then the lungs will collapse and the lung volume it will decrease. And the difference between the now, what is surface tension of the alveoli and the surfactant? So basically, the surface tension it is resulting from the attractive forces between the liquid molecules which are lining the alveoli at the liquid, at the air and the liquid interface. Now it creates a collapsing pressure that is directly proportional to the surface tension, and it is inversely proportional to the radius of the alveoli, which is called as the Laplace law. So you can see here, now P is the pressure and T is the surface tension. R is the radius. So pressure, it is directly proportional to the tension multiplied by 2, but it is inversely proportional to the radius of the alveoli. So this is how we calculate the pressure of the alveoli, or the pressure by which the alveoli, they will keep themselves open. This is the pressure what we call as the surface tension, and it is also called as the Laplace law, in which the pressure, it is directly proportional to the tension and inversely proportional to the radius of the alveoli. When the alveoli, they are large, so they have low collapsing pressure and they are easy to keep open. But when the alveoli, they are small, they have high collapsing pressure. So, but when the alveoli, they are small, the alveoli, they will have high collapsing pressure and they are more difficult to keep open. And in the absence of surfactant, the small alveoli, they have a tendency to collapse. This condition, it is called as atelectasis, because when there will be absence of surfactant, the lungs will not be able, the alveoli, they will not be able to expand. So they will collapse. And this condition, it is called as ectasis. Now, what is surfactant? It is a substance which is lining the alveoli, and it helps in reducing the surface tension by disrupting the intermolecular forces between the liquid molecules. It causes reduction in the surface tension, preventing the small alveoli from collapsing, and it also causes the increase in the compliance. Now, this alveoli, it is secreted by type 2 pneumocytes or type 2 alveolar cells. And this surfactant, it is composed, the composition of the surfactant is, it is a phospholipid which is called as dipalmitoyl phosphatidyl Now, this question, it is asked in the exam, that what is the composition of the surfactant? And the option that you are given is this one, the dipalmitoyl phosphatidylcholine. And you will also have to choose this in the exam, which is the correct option. But in the fetus, the surfactant synthesis is variable. The surfactant, it may be present as early as gestation of 24 weeks, and it is almost always present by week 35. Generally, a lecithin and a sphingomyelin ratio of greater than 2:1 in the amniotic fluid, it reflects the mature level of surfactant. So this question and this question, it is frequently asked in the exam. In every recall question, lecithin and sphingomyelin. So it is 2.1. And what is the composition of the surfactant? It is a phospholipid which is called as dipalmitoyl phosphatidylcholine. And what is respiratory distress syndrome of the neonate? It occurs in premature infants because of the lack of surfactant. And the infant, they exhibit lung atelectasis, because that means the lungs will collapse as the surfactant is not there, causing difficulty in reinflation of the lungs, and there will be hypoxemia as a result of decreased ventilation and the perfusion of the lungs. So, Nupur, will you summarize for me, please, the
Yes, ma'am.
mechanism of breathing? Yeah.
Yes, ma'am. Ma'am,
Okay.
diaphragm is the most important muscle for respiration. When it
Hmm.
contracts, the abdominal organs are pushed down and the ribs are moved outwards and upwards. So this causes increase in the lung volume and then inspiration. Also, expiration is a passive process because of the elastic recoil of the lung. This happens in normal, silent, quiet breathing. But in exerted breathing, we use our accessory muscles of respiration. That is, for inspiration, we use external intercostal muscle and accessory muscle, and for expiration, we use abdominal muscles and the internal intercostal muscle. The abdominal muscles, they push the viscera inside and thus the diaphragm up, which cause reduction in the lung volume and which helps in respiration.
Hmm.
And, uh, then we studied, ma'am. What did you say next, ma'am? What was it? Uh,
The
Sorry,
compliance,
ma'am.
the
Yeah,
lungs.
compliance is the volume,
I
the volume change upon the pressure, that is V by P. It is same as that of blood vessels. So it represents the elasticity of the lungs. The more elastic the lung, the less will be the compliance. Uh, then hello, huh. Yeah, and hello, hello.
transmural pressure before.
Uh, yes, ma'am. Transmural
Yes.
pressure. Yeah, transmural pressure is the pressure of the alveoli minus the intrapleural pressure. So it indicates the
Hmm.
distensibility of the lung. That is, if the pressure, intrapleural pressure, is negative, then the lungs will expand, and if the intrapleural pressure is positive, then it will push
Hmm.
the lung inwards and it will try to collapse the lung. So breathing will become difficult.
Yes, will become difficult.
And
And
then
then we had,
surfactant, ma'am. The action of
yeah, the
surfactant.
certain. Hmm.
The surfactant, it reduces the surface tension. So
Hmm.
uh, the pressure required to keep the lung patent is equal to twice the surface tension upon the radius. So, if the tension is more, then more pressure will be required. It will be more difficult to keep the lungs patent. And if the radius is small of the alveoli, then also it will be more difficult to keep the lungs patent. Surfactant is a substance that helps in reducing the surface tension. So, in human beings, it is a phospholipid, that is dipalmitidyl phosphatidyl choline (DPPC), and it is normally produced
Hmm.
by type 2 pneumocystes or type 2 alveolar cells. And in neonates, the fetus, the time of production is variable. It is between 24 weeks to 35 weeks, but usually it is
Hmm.
present after 35 weeks. Also, when the surfactant is
Yes.
absent, it leads to respiratory distress syndrome in neonates. Because of the absence of surfactant, the the alveoli collapse, and therefore there is hypoxemia and less exchange of gases. And also, the surface tension is the tension produced because of the interaction of the liquid molecules lying the alveoli with that of air at the air water interface.
What will happen in case of respiratory distress syndrome?
Ma'am, there is deficiency of surfactant.
Mhm.
Therefore, the infant, therefore, the surface tension will increase, and hence the small alveoli will collapse, and therefore there will be no exchange of gas, or like less exchange of gases. So, therefore, there will be hypoxemia
There will be hypoxemia
and
to the
respiratory
venous
disease.
and
Hello,
there will be ratio. Can you hear me?
Dr. Aksa, you can share the screen. Dr. Aksa, please share the screen. Oh, sorry again, that is disconnected. Dr. Aksa, you can share the screen now.
Yeah, so this is what happens in case of the neonatal respiratory distress syndrome, like you described now. So now coming to the relationship pressure, the airflow and the resistance. So airflow, what is airflow? It is the force which is driven by, and it is directly proportional to the pressure difference between the mouth or the nose and the alveoli. Because whenever we are breathing the air from the nose, it goes to the alveoli, then finally to the bronchioles, and finally it is
ma'am.
to the
Ma'am, voice is
alveoli. So
cracking.
from the mouth to the oh, again it's cracking. Now is it better?
Yes, ma'am.
Yeah. So what happens? The airflow from the mouth to the alveoli, in the mouth, the pressure is higher. So when it reaches the alveoli, the pressure it is decreased. So this pressure difference, it is called as the airflow. Now this pressure difference, it is inversely proportional to the resistance. And so whenever the resistance is going to be higher, the airflow will be lower. So you can see here that Q equals to P upon R. Q is the airflow, or if we talk about CVS, it was the blood flow, this Q, and P, it is the pressure difference, that is from the mouth to the alveoli, and R is the resistance. So so when we divide the pressure divided by the resistance, it gives the value which is called as the airflow. So we can see here that that airflow, it is directly proportional to the pressure, but it is inversely proportional to the radius of the the resistance of the alveoli. Now the resistance of the alveoli, it is calculated the same way as like yesterday we calculated for the cardiovascular system, that is R equals to 8 into N equals to the viscosity, L equals to the length of the airway. In that the air length was the length of the blood vessel. Here in respiratory system, the length is the length of the airway, and R is the radius of the airway. So we can see here that resistance, it is directly proportional to the length of the airway and the viscosity of the air, gas, the inspired air that we are inhaling, and it is inversely proportional to the radius. So radius to the power of 4, you can see here the same formula it is. So if we increase the radius by a factor of 4, then what will happen? If the radius decrease, the resistance will increase because they are opposite to each other, or they are indirectly related to each other. So the airflow, it will decrease by 256, because when we multiply 4 into 4, 4 was a 16, and 16 into 4, it becomes 256 in total. So the airway resistance, it decreases by 256. So Farah, will you summarize for me the two formulas, please?
Yes, ma'am.
Okay.
Ma'am, first relationship
The
between the
airflow? Yeah.
first the relationship between pressure, airflow, and resistance. No,
Hmm.
airflow.
Yes, airflow.
Airflow is driven by and is a directly proportional to the pressure difference between the mouth and the alveoli, and inversely proportional to the airway resistance. And formula is Q is equal to delta P divided by resistance, where Q is
Hmm.
the airflow and delta P is the pressure gradient, and
Hmm.
R is the resistance, airway resistance in centimeters of water per liter
Yes.
per minute.
It is the airway. Yeah. It is the. And what
Air,
is the resistance of
airway
the
resistance.
airways?
Resistance R is the by the equation and formula 8 NL divided by
Hmm.
pi R 4 R 4, 4
Yes.
with power of 4, where R is the resistance, N is the viscosity of gas which is inspired, and L
Hmm.
is the length of the airway, and R is the radius of the airway.
Hmm.
And it is similar to the like we
Yes.
measure the resistance in blood vessel. And so if the radius of the airway is 4, then when 4 is multiplied by 4 times, it will be 256, and the airflow will be decreased by factor 256. Hello, can you listen? Can you hear me? Hello,
Yes.
but Dr. Aksa's voice is not. Hello, ma'am, are you there?
Yes, Fakra, you were telling us about the
Mm, yes,
uh,
ma'am. I was telling
yes.
about resistance of the airway. That
Hmm.
was the formula. Resistance is equal to 8 NL divided by
Hmm.
pi R4,
Hmm.
where R is the resistance and N is the viscosity of the
Hmm.
gas which is inspired, and L is the length of the airway, and R is the radius of the airway. And if
It
airway
is the.
radius
Hmm.
is 4, then
Hmm.
resistance will increase by factor. If we multiply 4 by 4 times, then it will be 256, and airflow will decrease by factor
GG.
of about 256.
Okay, thank you.
See, it is similar to that in like a blood vessel. Formula is like that we have used in
In the
for
blood
blood
vessel,
vessel resistance.
for in the cardiovascular system that we have used.
Yes.
Yeah. So can we take 5 minutes break for Maghrib namaz and then we can continue, please?
Yes, ma'am.
Okay, thank
Yes,
you so
ma'am.
much. Okay. जी, hello. जी, आपने मुझे अच्छा तो फिर स्टूडेंट्स को भी बोलो ऐसे ही लोग उनसे लॉगिन होते हैं अच्छा सिर्फ बस मैं इससे सिर्फ लॉगिन है ओके हम्म हम्म आ जाऊँ अच्छा के देखते ओके ओके ओ थैंक यू सो मच So let's start back again. So now Fakra described us about the airflow and the resistance of the airways, same way like as the resistance of the blood vessels. So now moving to the breathing cycle, like we had the cardiac cycle in CBS, now we have the breathing cycle in case of respiratory system. So at rest, what happens when the person is doing no activity? So that is before the inspiration, that is before we start to inhale the air inside the lungs, what happened, the pressure of the alveoli, it is equal to the pressure of the atmosphere. So normally the atmospheric pressure which we take is 760 millimeters of mercury. That is the normal atmospheric pressure. So that means the atmospheric pressure is equal to the alveolar pressure, because the lung pressures, they are expressed relative to the atmospheric pressure. Alveolar pressure is said to be zero at this point. So you can see here at rest, this is the 0 point, because this is -3, this is 0. That is the rest point in cases of inspiration. And also at expiration, the rest, at rest, it is 0. The pressure is 0. Now what happens when the intrapleural pressure becomes negative? What we studied with when the pressure outside the lung, it becomes negative, the lungs, they can expand and the air will come inside the lungs. So what happens at the force residual capacity, the opposing forces of the lungs, they try to collapse and the chest wall is trying to expand, creating a negative pressure in the intrapleural space between them. Now this intrapleural pressure, it can be measured at the balloon catheter in the esophagus. Now in the exam, the question was asked that at what point of the breathing cycle we can measure the intrapleural pressure. So this is the second step of the cardiac cycle. That is when the intrapleural pressure is negative, we can measure the pressure by a balloon catheter inserting into the esophagus. And then the lung volume. So when the person inhales the air, the lung volume, it reaches to the force residual capacity. That is called as the the amount of inhaled air, it reaches to the value which is called as force residual capacity, that the total volume of which is the expiratory reserve volume plus the residual volume, which is equal to 2300 ml. Then what happens? Now the inspiration begins. So now the inspiration will begin. You can see here now this is the rest and now the inspiration will begin. When the inspiration begins, so now we will study that what happens. So what happens when the inspiration it starts. So what happens? The inspiratory muscles, they contract and it causes the volume of the thorax to increase because the muscles, they are contracting. So the volume will increase. So as the volume of the lung, it increases, the pressure of the alveoli, it decreases because the pressure is inversely proportional to the volume, to less than the atmospheric pressure. So it also becomes negative. So the alveolar pressure, it becomes negative. So you can see here in the diagram that the alveolar pressure, it gets decreasing. That is the minus value. In cases of inspiration, the alveolar pressure is decreasing. Beyond, it is 0, above is plus, and below is minus. So you can see here now the alveolar pressure, it is decreasing. Now the pressure gradient, which is from the mouth to the alveoli, that is called as the pressure gradient in cases. So now the pressure gradient here, it is between the atmosphere and the alveoli. Now it causes the air to flow into the lungs. So air will go into the lungs. The airflow will continue until the pressure gradient, it dissipates. Until the pressure gradient, it becomes equal from the mouth, from the atmosphere to the alveoli, or from the mouth to the alveoli. Now what happens? Then the intrapleural pressure, it becomes negative. So you can see here the intrapleural pressure, it is becoming negative during the inspiration process. That is -3. and then it reaches to -3, and then in expiration it again reaches back to the same value. So what happens when the intrapleural pressure it becomes negative? So what will happen? The lung volume will expand and the air will go inside the lungs. So because the lung volume increases during inspiration, the elastic recoil strength of the lung it also increases. As a result, the intrapleural pressure it becomes even more negative than it was at rest. So changes in the intrapleural pressure during inspiration they are used to measure the compliance, the dynamic compliance of the lung. And compliance it is equal to C equals to volume divided by the pressure. So this compliance, when we talk about in terms of breathing cycle, so it can be measured during the inspiration process of the breathing cycle. And the lung volume then increases by one tidal volume. That is, at the peak of the inspiration, the lung volume is not only tidal volume, but it is also the forced residual capacity, which is equal to 2300 ml. So the lung volume will become the tidal volume plus the force residual capacity. Now what happens during the expiration? So during the expiration, now the alveolar pressure is high because now the air is inside the lungs because all the air we have inhaled it. Now air has to come out of the lungs to be expired. So now the alveolar pressure, it is greater than the atmospheric pressure. That means the pressure inside the lung is outside the lungs, it is positive. So what will happen? The lung will collapse and the air will come outside of the lungs. So what will happen? The alveolar pressure, it becomes greater, that is positive, because the alveolar gases, they are compressed by the elastic forces of the lung. Thus, the alveolar pressure is now higher than the atmospheric pressure and the pressure gradient is reversed. That is from low, that is inside will be higher and outside will be lower. So the air always flows from the region of high to low. So the air will go outside so the air will come out of the mouth. That is, we are breathing the air out. That is expiration. And then what happens? The intrapleural pressure, it then returns back to its resting value during a normal passive expiration. So you can see here, now initially the pressure was in negative. Again, the pressure got negative. But when the expiration begin, the pressure, it is negative. But then it comes to a point which is called as the resting point. That is when the air, it has completely expelled out of the lungs. So what happens during, if the patient is doing any, if the person is doing any exercise, so in cases of forced expiration, the intrapleural pressure it actually becomes positive. Now this positive intrapleural pressure it compresses the airways and it makes the expiration more difficult. Now in cases of COPD, now COPD is an example of an obstructive disease. So what happens in case of obstructive disease? The airway resistance is increased. We studied previously that the airway resistance increase. So patient has to expire slowly with pursued lips. So the patient it makes a like a vessel shape of the lips so that to prevent the airway to collapse and it may occur with a forced expiration. And again, once the expiration it has been completed, the lung volume it returns back to the forced residual capacity. That is the amount of air which is remaining in the lungs after the tidal volume is expired. That is residual volume plus the expiratory reserved volume. That is 2300 ml. So now you can see here, this was the inspiration and this is the expiration. So again, when it started from 0 in cases of alveolar pressure during inspiration, and when it is ending, the expiration is ending, again it reaches back to 0. In cases of intrapleural pressure also you can see it is starting from -3 going downwards and again it is coming back to the same point. Ultimately the inspiration and the expiration they are coming at a same level. And also you can see the volume of breath. It is starting from 0 at rest. It is rising when the air, when we are breathing the air inside, and when the air goes out of the lung, Again, it comes back to rest. Okay, so now what will happen in the lung conditions like lung diseases, that is asthma, which is an example of obstructive disease, and COPD also, which is an example of obstructive disease. So we just studied that in COPD, the airway resistance is increased and the patient, it has to make the lips pursuit shape or the vessel-like shape of the lungs will be there so that if the patient is able to forcefully expire the air out of the lungs. So in asthma, it is an obstructive disease in which the expiration it is impaired. So the main cause of asthma is that the expiration is mainly impaired. Inspiration is fine, but the patient is having difficulty in expiring the air, or the patient will complain of that she is unable to breathe properly, or she can say that she is having shortness of breath. Now, it is characterized by decrease in the forced vital capacity, decrease in FE1, and decrease in FE1 and FEC. That is, in total, the both values will decrease in obstructive cases. And air that should have been expired, it is not expired, leading to the air trapping and increase in the total function, that is the functional residual capacity, because normally the air that should be expressed outside of the lungs, that is expired, it is not expired because of the obstruction which is present. So the amount of air inside the lungs, it is more. That is why there is an increase in FRC, that is the forced residual capacity, but the value in total will decrease, that is the FUE and FEC. Now, COPD, it is a combination of chronic bronchitis and emphysema. So it is also an example of an obstructive disease in which what happened, the compliance of the lung is increased and in which also the expiration is impaired. So when the expiration is impaired and it's an obstructive disease, so there will be decrease in FEC, FVC, FE1, and ultimately both the values will be decreased. So air, like asthma, the air is unable to go outside of the lung. So amount of air inside the lung will increase and the patient will have a barrel-shaped chest. Now what happens especially in cases of emphysema, this condition it is also called as pink puffers. Because why it is called as pink puffers? Because the air is inside the lungs and it causes mild hypoxemia, and because they maintain the alveolar ventilation and the carbon dioxide level, it is normal. Now, blue bloaters, it is the primary bronchitis. It has severe hypoxemia with cyanosis, they will be there, and because the patient is unable to maintain the alveolar ventilation, there will be increase in the partial pressure of carbon dioxide. And as a result, what happens ultimately when it is not treated, it can lead to failure, right ventricular failure, and the systemic edema, leading to ultimately it is leading to the heart failure. So these are the two conditions that you should know, that asthma and COPD both are the examples of obstructive disease in which there's an increase in lung compliance and decrease in FVE, and decrease in forced vital capacity also. And along with that, there will be increase in the forced residual capacity of the lungs. It will be increased. And specifically, if we talk about emphysema, that is a type of COPD. So what happens? There will be pink puffers and blue waters. These are the cases of bronchitis. Now, fibrosis, it is an example of a restrictive disease. So when is the restrictive disease? There will be decrease in lung counts. So inspiration is impaired. So you can see the difference in both of them. Will be affected when there is going to be an restrictive lung disease. The inspiration is affected. So what happens? It is characterized by decrease in all the volumes of the lung. And because FE1 is decreased, less than FE1, FVC, that is forced vital capacity. So ultimately, the whole value it is either it is going to be increased or it may be normal. So if I talk about in terms of the differences, so you can see here very simple and a very beautiful chart. You can see that the forced expiratory volume, it is decreased in case of asthma and COPD, and or the forced vital capacity, it is decreased in cases of asthma and COPD, but it is less decreased as compared to FEV, that is the forced expiratory volume. And then ultimately the value, the total value is also decreased, but the FRC, that is the force, that is the functional residual capacity, it will be increased. So asthma and COPD, they are example of obstructive, and fibrosis, that is an example of a restrictive lung disease, in which the FEV is also decreased, the FVC is also decreased, that is forced vital capacity, but the total value, it is either it is going to be normal or it is going to be increased, but the total functional residual capacity, it is then decreased in cases of restrictive lung conditions. So Nupur, will you summarize for us this, the breathing cycle?
Ma'am, I missed the first slide.
Okay, no problem. So, okay, so you start from where I will be adding you.
Okay, ma'am, I started from inspiration. Like I know how inspiration starts. Before that, I missed it. So just the first slide,
So
ma'am, if you
before
can add.
inspiration, what happens? So before inspiration, okay, no
Yeah,
problem.
ma'am,
So
this one.
before inspiration, what happens? It is the period of rest when the person is about to breathe. So before that, the alveolar pressure, it is equal to the atmospheric pressure. That is, atmospheric pressure is 760 millimeters of mercury, while the alveolar pressure, it is going to be 0. Then as the patient starts to is about to breathe, what will happen, the pressure outside the pleura of the lungs will be negative. When the pressure becomes negative, so the lungs will expand and the air will go inside the lungs. That is, the process of inspiration has now started, and the lung volume will become to the FRC, that is functional residual capacity. Now
Okay,
begins
ma'am.
how the inspiration will take place. Yeah.
Yes, ma'am. Then there is contraction of the inspiratory muscle. So this causes
Hmm.
the pressure inside the alveolus will be less than the pressure in the atmosphere. Therefore, the air will come from out into the atmosphere. Also, the change in the volume will lead to more increase in the compliance, and this leads to more negative pressure in the pleura, and therefore intrapleural pressure is a measure of dynamic compliance of the lung.
Hmm.
Then at the peak of the inspiration, the lung volume is the FRC plus 1 vital capacity.
Yes. One vital capacity, no, function residual
Vital
capacity
tidal
plus,
volume.
plus,
Sorry,
yes,
sorry,
tidal volume. Yes, yeah,
tidal volume. Yes.
yes.
Then then the pressure in the alveoli when they are filled with the air, it increases that as compared to that of the atmosphere. Therefore, the
Hmm.
air moves out from the lungs into the
Hmm.
atmosphere, and
Hmm.
in some diseases, when exercise sorry in exercise, the intrapleural pressure, it becomes positive also. So then
Hmm.
when it becomes positive, it compresses the trachea and bronchi, and therefore it makes expiration even more difficult. So we have to make an effort to expire.
Yes.
Then in diseases, so this completes, like once we expire the air, then again it comes back to the normal, where the lung pressure inside the alveoli is equal to the atmospheric pressure, that is 760 millimeter of mercury, and intrapleural
Hmm.
pressure is also back to normal, uh, and slowly
Hmm.
then it becomes negative again, and then inspiration
Yes.
starts again.
Hmm.
Then in diseases like asthma, it
Hmm.
is restrictive obstructive lung disease. So there the FRs the forced expiratory capacity decreases, and also forced vital capacity decreases, but forced expiratory capacity decreases more. So therefore there is a net decrease. And
Hmm.
in diseases like COPD, which is a combination of emphysema and chronic bronchitis, both
Hmm.
it is also similar to like forced expiratory volume decreases and vital capacity also decreases, but the decrease is more in forced expiratory capacity. Also, the air is trapped inside the lungs, as it is not because of the obstruction we are not able to fully expire the air. So there is trapping of air inside the lung. In emphysema, this is in a this causes pink puffers because it is mild and the ventilation is still taking place. That is exchange of oxygen from air to blood. But in chronic
Hmm.
bronchitis, this is severe and it causes bloaters, and it causes cyanosis and hypoxemia, and eventually right ventricular failure and systemic edema.
Yes.
In restrictive diseases like fibrosis of the lung, the FEV1
Hmm.
decreases, forced vital capacity also decreases, but forced vital capacity decreases more because the capacity of lung
Hmm.
itself decreases. Therefore, therefore the ratio might be increased or it might be normal.
Yes, it might increase or it may be normal. So only you can remember, oh, for easy remembrance we can always remember like this, that obstructive and restrictive disease. The examples of obstructive will be asthma and COPD. For restrictive it will be, the example will be fibrosis of the lung, and then we will have increase or decrease values,
Yes, ma'am.
just for easy remembrance. Now coming to the exchange of the gas. So now exchange of the gases have to take place, like oxygen and carbon dioxide between the atmosphere and the lungs. So what happens? There is a Dalton's law of partial pressure, which says that partial pressure, it is equal to the total pressure multiplied by the fractional gas concentration. So what happens in cases of inspired air, that is the dried inspired air, the partial pressure of oxygen, it is calculated by as follows: that if the total pressure of atmosphere, it is normal, that is 760, and the fractional concentration of oxygen is 0.21. So we multiply 760 by 0.21, so we get the partial pressure of inspired air, dry inspired air. But when we talk about the humidified tracheal air, that is at the temperature of 37 degrees centigrade. So how we will calculate the partial pressure? It is calculated as 760 minus 47, because the normal pressure is 760, and in the question they have told us that the air is humidified. So that is, it is 47 millimeters of mercury. Sorry, it is given as 47 millimeters of mercury. So 760 minus 47, it is equal to 713. And when we multiply with the oxygen concentration, it is the same. So it becomes 150 millimeters. So you can see there is a small difference in between the inspired air, pressure of inspired air, and the pressure of humidified tracheal air. Now, what happens when we talk about the partial pressure of oxygen, carbon dioxide in cases of inspired air, the alveolar air, and in blood? So, approximately there is 2% of the systemic cardiac output which passes the pulmonary circulation, causing the physiological shunt. The resulting mixture of the venous blood with the oxygenated arterial blood, it makes the partial pressure of oxygen of the arterial blood to be slightly lower than that of the alveolar air. Now we'll talk about how the gases they are dissolved in the blood. The amount of gases which are dissolved in a solution such as blood, it is proportional to its partial pressure. That is, if the partial pressure of oxygen is 0.2, sorry, if the partial pressure of inspired air, it is 160 millimeters of mercury. So the amount of dissolved gas will also be 160 ml of 100 ml of the blood. Now, diffusion of gases such as oxygen and carbon dioxide, they have the diffusion of rates of oxygen and carbon dioxide. It depends upon the partial pressure difference between from the mouth and the alveoli. The difference will be between mouth and the alveoli across the membrane and also the area which is available for diffusion. Like mouth, it has a small surface area. The alveoli, it has a more surface area because the surfactant is present there, while the mouth, it has a small surface area. So you can see here, we are comparing the inspired air, the humidified alveolar air, the air alveoli, the systemic so oxygen in cases of humidified where it decreases because we 100 it reaches होने दो, लेकिन आप कर दो फिर भी।
नहीं होगा क्योंकि I have to close Zoom.
Dr. Aqsa, your host now. You can share the screen.
Okay.
सही है, thank
Assalamu alaikum, Dr. Aqsa. Please share the screen.
you. Yes. पे आ गया देखो क्यों बार-बार हो रहा है समझ
हमारे रूम में चली जाओ ये देखो सोच
चलो बैठ के देखते हैं रोज का ये तो हो गया हम कैसे
Dr. Aqsa, please share the screen.
So we were talking about the partial pressure of oxygen and carbon dioxide in respect to different amount of air. That is the inspired air, the humidified tracheal air, the alveolar air, the arterial blood, and the mixed venous blood. So the partial pressure of oxygen in inspired air, it is 160. When amount of water is added into it, the value, the amount, the pressure of the oxygen it decreases, and when it mixes with alveolar air, that's when it goes into the lungs. The pressure it decreases further from 150 to 100, and then when it mixes with the arterial blood, the pressure remains the same. But when the arterial and the venous blood it mixes, so the pressure of the partial pressure of the oxygen it decreases. That is ultimately from there will be no when it reaches to the alveoli 40 Is my screen visible now?
No, ma'am, screen is not
Oh.
visible.
Oh, not visible. Okay. Let me check. Why is it not visible? Hello. Is the screen visible now?
Now visible.
Transport. Okay, okay. Thank you so much, Fakra. So now coming to the transport of oxygen. Now the oxygen, it is carried in the blood into is the dissolved, and some of the oxygen it is bound to hemoglobin. Hemoglobin is normally oxygen capacity of the several times in the recall that how much is the by how much four. So the molecular protein that is to see the fetal hemoglobin, it is called as the hemoglobin F. Now this fetal hemoglobin this fetal hemoglobin it has the fetal hemoglobin, the beta chains is the fetal hemoglobin is effort to alpha. So we'll just in the recording. Hmm. ओके, तो अभी ऐसा करूं? अभी आता है घंटा अंदर। तो मैं कहाँ पे लगाऊं? So what happens? We have oxygen, which is transported into the blood in two forms. Either oxygen is bound in the dissolved form, or it is transported in the, which is bound to the hemoglobin. So hemoglobin, adult hemoglobin, it has two alpha and two beta unit, and alpha beta line for hemoglobin, it is hemoglobin. मुझे बता दें, मैं भी कर लेती हूँ। जी, आप मुझे अभी बता दें कैसे Is my voice audible, Fakhra, now to you?
Yes, ma'am. Now audible.
Okay. I was asking. I thought my mic was muted. Okay, that's fine. So now we have hemoglobin and we have methemoglobin. So methemoglobin, in which the iron is Fe3 plus. In normal hemoglobin, iron is O2 plus. And it causes sulfur disease. Form that is form hemoglobin. It can be bound to the hemoglobin that can be carried in the blood. It is at 100% saturation of and the what is oxygen transfer, Fakra?
Yes, ma'am. मेरे पास रहे कि आवाज ही नहीं Delton stuff.
Can you hear me? I hear you. Your voice is audible.
उनका नेट नहीं चल रहा मेरा चल
Yes, now I can hear you. Yes. So I will sum dissolved and the bound oxygen to the hemoglobin. So hemoglobin, in which the oxygen carrying capacity is to 74. The the that in form of Fe adult hemoglobin beta 2 units, while the fetal alpha hemoglobin hemoglobin iron E3 with hemoglobin which can be dissolved form or now oxygen dissociation and oxygen oxygen dissociation that means what happens that all of the 4 units that means all of the 4 units of hemoglobin all of the 4 units of iron they are bound with oxygen but when the partial pressure of oxygen it becomes to 40 meters of it is mixed blood so molecules hemoglobin they have an oxygen. So one molecule emptied, it will
Dr. Aqsa, are you there?
the oxygen. When
Okay, thank you.
yes,
Ma'am, no voice can be here. Distortion in voice.
means that only the 50% of the molecules of oxygen will be bound, and not have oxygen. The so the sigmoid shape of the curve, what it causes the sigmoid shape of the curve. It is
Ma'am, distortion in voice. No voice.
now it is a result in the G. GIT. So in the lungs, the alveolar gas, it has a partial pressure of oxygen of 100 millimeters of mercury. And the pulmonary capillary blood, it is arterialized. What does arterialized mean? It means that the oxygen is diffused from the alveolar gas into the blood, so that the partial of So what happens in cases? Arterial. So when in cases of graph, there will be loading Okay, I'll summarize it quickly for you. I will summarize it very quickly. The 75. So when the partial pressure of the oxygen when the partial pressure of be and there will be unload so it will partial pressure of carbon dioxide or decrease in pH. So the curve will shift towards the right side or like see when Fakra, are you able to hear me? Please, can you acknowledge me for that?
Yes, ma'am, I can hear, but there was so distortion in class.
Oh, there was disturbance. So I was saying, and I thought your mic was muted. I tried to unmute you. Okay, no problem. I'll do it from here. No problem. So what is so we have the hemoglobin dissociation curve, which will shift either towards the right side or it will shift towards the left side. So when it shifts towards the right side, so what happens? It allows the delivery of oxygen to the tissues. That is when there's increase in temperature, when there's increase in pH.
Yeah.
So in this condition, what happens? The oxygen it is moved. So, but opposite will help when the curve it moves towards the left side. So when the oxygen dissociation curve it moves towards the left side, so the affinity of hemoglobin for oxygen is increased, and the oxygen there is now unloading of oxygen will take place from the blood into the tissues. It is more, then it gets difficult. While when it moves towards the right side, the curve it moves towards the right side, there will be shifting of oxygen towards the tissues, that is loading, and on the left side there will be unloading or difficulty in loading of tissues with oxygen. So for any level of partial pressure of oxygen, the person's saturation of hemoglobin and thus the oxygen content of the blood it is increased. So when the curve is shifted to the left, so it is the mirror image as to the right. Only the difference is that there will be decrease in carbon dioxide, increase in pH, decrease in temperature. All will be decreased except the pH, which is increased. And it is opposite to the when the curve shifts towards the right side. Is it clear till here, Fakra, to you?
Yes, ma'am.
Okay, perfect.
Shift
So
toward
now
normal is
the right,
normal is normal is right side shift.
no, normal is like this. Let me show you how is normal. Normal is like this green line. You can see this
Yes.
green line, it is normal. And when it is shifted towards the right side, this is the right,
Hmm.
and this is
Yes.
the, yeah, and that is the left side.
Yellow is left.
Yes, the yellow is, then this is the green one is the normal one.
Okay.
So now what is hemoglobin F? Hemoglobin, fetal hemoglobin, it does not bind with 2,3-DGB as strongly as does the adult hemoglobin. So it resulting in decreased binding of 2,3-DGB. It results in increased affinity of hemoglobin for oxygen, resulting in decreased P50 value, and the curve shifts towards the left side. So with
Left.
also with fetal hemoglobin, the curve will move towards the left side.
Yeah. And more affinity for oxygen.
Yeah, more affinity for oxygen.
Okay.
So when with carbon monoxide poisoning, what happens in with carbon when there is carbon monoxide poisoning? So carbon monoxide it competes with the oxygen binding sites on the hemoglobin, and the affinity of hemoglobin for carbon monoxide it is 200 times more than the oxygen. So in the exam, they will always ask this question that how much is the affinity for carbon monoxide? It is 200 times. In the recall questions, you will find it. So carbon monoxide, it occupies the oxygen binding site on the hemoglobin, thus decreasing the oxygen content of the blood, resulting in causing the curve towards to be shifted to the left side. So can you tell me how many, why, when does the curve shift towards the left side? In what conditions?
In carbon monoxide poisoning
Hmm. Yes.
and if and HbF fetal hemoglobin
Hmm.
also
Yes.
shift towards the left.
And also in which other
And
conditions?
other
When there's decrease in carbon
then
dioxide.
then decrease in when affinity for oxygen is decreased
Hmm.
and decrease in carbon dioxide also causes when pH is increased and decreased
Hmm.
temperature.
Hmm. and also decrease in 2,3
Yes, 2, 3
DPP.
dP
Yes,
concentration also decrease.
yeah.
It also
So they all
shifts the
will,
curve.
yes. So the curve will shift to the left
Left
side,
side,
and
left side.
there will be unloading of oxygen from the blood into the tissues.
Tissues. Yeah.
Yes, yes. So now what is hypoxemia? Hypoxemia means that there is decrease in the arterial partial pressure of oxygen, and it is caused by decrease in the partial pressure of oxygen. There will be diffusion defects, VQ defects, and the right to left shift. So you can see in when there is high altitude, so partial there is hypoxemia, partial pressure of oxygen, it is decreased.
Decrease.
Hypoventilation also it is decreased. When there is fibrosis, then also the partial pressure of oxygen it is decreased. And in cases of VQ defect, the partial pressure of oxygen again it is decreased. And when there is right to left shift shunt, so also again the partial pressure of oxygen it decreases.
Right.
So these are the condition in which the partial pressure of oxygen it is decreased in
Decrease.
all of the cases. And what is hypoxia? Hypoxia means that
Yeah.
delivery
Less
of
oxygen.
oxygen, yeah, oxygen will be less delivered to the tissues. So what will happen? There will be less cardiac output, decreased cardiac output, hypoxemia, and there will be anemia. It can occur in cases of carbon monoxide poisoning and also in cases of cyanide poisoning. So can you now tell me what are the causes of hypoxemia and hypoxia?
Uh, when they decrease cardiac output
Hmm.
and when anemia and
Yes.
and in hypoxemia, that
Hmm.
is decreased oxygen in the blood, and
Hmm.
carbon monoxide poisoning and cyanide poisoning when
Yes.
utilization of oxygen is decreased.
Yes. Erythropoietin, it is a growth factor which is synthesized by the kidney, and in response to when there is hypoxia, it causes the formation of
And please share slide.
erythropoietin. Oh, you
Please share
cannot see?
slide. No.
So when erythropoietin, yes, yes,
Erythropoietin.
okay, yeah. Can you see now my slide?
Yes. 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 Erythropoietin is produced by kidney in hypoxic
So
conditions.
what happens when there's oxygen hypoxia? Yeah. So it causes the promotion of it causes the production of mature RBCs.
Uh, So more RBCs will be
Yeah.
produced.
So more RBCs will be produced. That means more oxygen will be
Okay.
now will be
Carried.
available
Okay.
like this.
Carrying capacity will be
Less
increased.
oxygen. So now coming to
Yes.
carbon dioxide. So yes. So carbon dioxide it is produced in the tissues and it is carried to the lungs in the venous blood in three forms. It is dissolved carbon dioxide, which is very soluble in water. It is liquid carbon dioxide, which is soluble in water. And it is gaseous carbon dioxide, which is insoluble in water. So carbon dioxide it is produced in the tissues and it is carried to the lungs in the venous blood. Carbon dioxide it is generated in the tissues and it diffuses freely into the plasma and then into the RBCs. From the RBCs, the carbon dioxide it combines with the water to form what is called as bicarbonic acid. Now this reaction it is catalyzed by an enzyme called as carbonic anhydrase enzyme. Now this carbonic acid it is used to oxidize the RBCs in exchange for chloride, which is called as chloride shift. So this is the RBC and the bicarbonate chloride, it will come inside. You got my point?
Yes, RBC
Okay.
and
Yes.
chloride.
Yes. Yeah. Chloride will come inside the cell, while the bicarbonate it will go out of the cell.
Okay.
So you can see here, this is the RBC. Carbon dioxide is coming into the RBC. This combines with water to form this bicarbonic acid, and this then dissociates into H plus and bicarbonate. Now it is bicarbonate is going outside and chloride is coming inside the RBC. This is called as chloride shift.
Chloride shift.
Now the hydrogen, it is buffered inside the RBCs by deoxyhemoglobin, because deoxyhemoglobin, it is better buffer for hydrogen than is oxyhemoglobin. So it is advantageous that hemoglobin has been deoxygenated when it reaches to the by the time it reaches to the venous end of the capillaries, that is the site where the carbon dioxide is being added. But in the lungs, what happen? All of the reactions, they occur in opposite. Bicarbonate will enter the RBC in exchange for chloride, and when it combines with the hydrogen ion, it forms a bicarbonic acid, which decomposes into carbon dioxide and water, and thus carbon dioxide, which is generated in the tissues, it is expired out of the air.
Yes.
So you understood now?
Yes, ma'am.
Yes, very
In
good.
lung, bicarbonate
Hmm.
enters the RBC
Hmm.
and combined with the chlorine and in exchange of chlorine and bicarbonate,
Yes,
recombine and form hydrogen ion and bicarbonate.
yes, yeah,
And,
it
the-
forms.
and bicarbonate decompose into carbon dioxide and water, and dioxide excreted through the lung, expired through lung.
Yes, it is expired then through the lungs. Very good. So now what is pulmonary circulation? So now the pressure and the cardiac output in the pulmonary circulation. So pressure of the pulmonary circulation, they are much lower than in the systemic circulation. So the pulmonary arterial pressure, it is 15 millimeters of mercury, while the aortic pressure, it is 100 millimeters of mercury. And the resistance, it is also much lower in the pulmonary circulation than in the systemic circulation. And cardiac output of the right ventricle, it is called as the pulmonary blood flow, which is equal to the cardiac output of the left ventricle, that is aorta. And also the pressures in the pulmonary circulations, they are low. They are sufficient to pump the cardiac output, because resistance of the pulmonary circulation, it is proportionally low. Now so will you summarize this part for me, the pulmonary circulation, Fakra?
Yes, ma'am.
Okay.
Because pressure in pulmonary circulation is low, that is 15 millimeter of mercury, and aortic pressure is 100 millimeter of mercury.
Hmm.
And resistance in much lower in pulmonary circulation as compared to systemic circulation. So, cardiac output of the left ventricle is pulmonary blood flow is equal to the cardiac output of the left ventricle,
Hmm.
and the pulmonary circulation pressure is low,
Low.
and
Hmm.
so there's sufficient pump to the cardiac output, because the resistance of pulmonary circulation is low as compared to aortic circulation,
Yes.
aortic pressure.
Yes, very good. Yeah, you've explained me really very beautifully.
Thank
So
you.
now, no problem. So now coming to the distribution of the blood flow, how does the pulmonary blood flow it occurs? So when the person is supine, that is when the person is in sitting position, so the blood flow, it is nearly uniform throughout the whole of the lung. But when the person is standing, so blood flow, it is evenly distributed because of the effect of gravity. The blood flow, it is lowest in the apex and highest at the base of the lung. So zone 1, the blood flow is lowest, but the alveolar pressure is higher here. So you
Alveolar.
understood? Yeah. So in zone 1, blood flow. Now, if I divide the lung, this is the lung. Let's suppose this is the lung. So this is the zone 1, zone 2, and zone 3. So in zone 1, what will happen? The blood flow will be low and the alveolar pressure will be high. And what the high alveolar pressure, it compresses the capillaries and reduces the blood flow in zone 1. This situation it occurs if the arterial blood pressure it is decreased as a result of bleeding, or if the alveolar pressure it is increased because of positive pressure ventilation. Now what happens in case of zone 2? Zone 2, it is everything is in medium. The blood flow and the pressure, they both are in the
Medium.
medium range. So
Central
arterial pressure,
zone.
yeah,
And
this is,
central zone is zone 2.
yes, central zone. Yes, you can say it is the central zone in which everything will be, blood flow will be medium.
Medium.
Yeah. And the moving down the lung, the arterial pressure increases because of the gravity, and arterial pressure it is greater than the alveolar pressure in zone 2, and the blood flow it is driven by the difference between the arterial and the alveolar pressure. Now what happens in zone 3? The blood flow it is highest, and also,
Yes.
yeah, the arterial pressure is also highest. So moving towards the base of the lung, the arterial pressure is highest because of gravity, and the venous pressure it finally increases to the point where it exceeds the alveolar pressure. So in zone 3, the blood flow it is driving between the arterial and the venous pressure, as in most of the vascular blood. So now will you tell me that what happens in zone 1, zone 2, and zone 3?
In zone 1,
Hmm?
the distribution of blood alveolar pressure, and
Hmm?
then arterial, and then venous pressure.
Hmm?
Um, uh, so
In zone 2?
um, in zone 2, it is arterial pressure is more, and then
Hmm?
alveolar, and then venous pressure.
Yes.
And because it's in zone 2, all pressures are medium.
Hmm.
Mm,
All the blood
and
flow is medium.
all the blood flow is medium,
Hmm.
and the arterial pressure is greater than the
Yes.
alveolar pressure in zone
Hmm.
2, and
Yes.
blood flow is the difference between the arterial pressure and alveolar pressure. And the
Yeah.
zone 3, blood flow is highest due to the gravity, and
Hmm.
yeah, in the arterial pressure is higher, and then
Hmm.
venous pressure, and then alveolar pressure increase.
In
Initially,
zone. Hmm.
lowest is the arterial, and then venous increase, venous, and then alveolar
Yes.
increase.
Yes. In zone 3.
Yes, and
Yes.
because in the base of the lung, arterial pressure is highest
Hmm.
because of the
Yes. Because
gravitational
of,
effect.
yes, because of the, and what will happen in the, when will happen in the supine position?
Supine position, it will be when blood flow is uniformly throughout the body, throughout the lung,
Hmm. Yes.
and the one person is standing, blood flow is unevenly distributed because of
Yes.
the effect of gravity,
Gravity. Yes. It is
and
all because the effect of gravity.
lowest at the apex and highest at the base of the lung.
Yes. Lowest at the base and highest at the lung. Yeah.
No,
Very
apex at the apex lower, and the base which
base
is
highest.
base which is lower side of the lung
Hmm.
is highest.
Yes, it will be highest. Now, what happens to the pulmonary blood flow? That is hypoxic vasoconstriction. So, in the lungs, whenever there's going to be hypoxia, that is decreased oxygen to the tissues. So, hypoxia will cause vasoconstriction. But it is opposite to that of the other organs, where hypoxia causes vasodilation. So, very important point that in the lungs, hypoxia causes vasoconstriction, while in other organs, it causes vasodilation.
Again.
Hmm. Physiological, this effect is important because the local vasoconstriction it redirects the blood away from the poorly ventilated hypoxic regions of the lung and towards the well ventilated region. Now, what happens in case of fetal pulmonary vessels? The fetal pulmonary vascular resistance, it is very high because of the generalized hypoxic vasoconstriction. As a result, the blood flow through the lungs of the fetus, it is low.
Low.
With the first breath, the alveoli of the neonates, they are oxygenated. Pulmonary vascular resistance, it decreases, and the blood flow, it increases, which becomes equal to the cardiac output as in the adults. So only thing that you need to remember, that hypoxia in the lungs, it causes vasodilation or vasoconstriction.
Vasoconstriction.
Yes. In
Because
the other organs, it will
in the
cause.
other organ, due to hypoxia, there is vasodilation.
Yes, very good. So now what is right to left shunt? So in right to left, there are two shunts. That is the right to left shunt and left to right shunt. Normally, it occurs in a small extent because 2% of the cardiac output, it bypasses the lung. And the examples of right to left shunt, they are Petrology of Fallet, in which there will be decrease in the partial pressure of oxygen because there will be mixture of venous and the arterial blood. That is why. And what happens in left to right shunt? Left to right shunt, it is more common than right to left shunt because the pressure in the ventricles, it is higher on the left side of the heart, and it is caused by like patent ductus arteriosus or when there is traumatic injury. It does not result in the decrease in the arterial partial pressure of oxygen. When there is right to left shunt, partial pressure of the oxygen in the arterial blood, it will decrease. But in cases of left to right shunt, there will be no decrease in the partial pressure of oxygen. Instead, the partial
Why,
pressure of
ma'am?
oxygen. Sorry, what did you say, Fakra?
What is the reason? What is the reason why in right to left shunt, partial pressure of oxygen decreases, but in left to right shunt, there is no change?
Yes, you tell me why. Because when there is right, because this is because in the right to left shunt, right on the right side of the blood, it is the venous blood. That is
Venous
the
blood.
deoxygenate. So venous and arterial blood, it mixes. That is why the
Okay.
yeah. So it decreases. But in case of left to right shunt, left is already has the oxygen blood.
Okay.
So it does. That is
So
why it does not
no
decrease.
change.
Yeah, no change, or there will be no decrease in the partial pressure of
Oxygen.
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 Now, what is VQ defect? V means the alveolar,
Ventilation.
yeah, ventilation.
Ventilation perfusion.
Yes, yeah, ventilation, and Q is the blood flow. So ventilation and perfusion, it is to achieve the ideal exchange of oxygen and carbon dioxide. So if the breathing rate, the tidal volume, and the cardiac output, if everything is normal, the VQ ratio, it is normally is 0.8. This is the normal value of VQ that you need to remember. Now, this VQ
Okay.
ratio, it causes an increase in arterial, it results in arterial partial pressure of oxygen of 100 millimeters of mercury, and pressure of carbon dioxide will be 40
40
millimeters of mercury.
mercury.
Yes. So now you can see in the apex of the lungs, that is zone 1, zone 2, and zone 3. In zone 3, there will be more blood flow, and in zone 1, there is less blood flow. In zone 1, there is less ventilation. In zone 3, there is more ventilation. So BQ will increase in zone 1 and it will decrease in zone 3.
Okay.
Yes, and partial pressure of oxygen, it is increase in zone 1 and decrease in zone 3.
Okay.
Carbon dioxide, it is opposite, decrease in zone 1 and increase in zone 3,
Okay.
like this. You understood now?
Yes, ma'am.
Now, yeah,
Okay.
now repeat, yeah, now summarize it for me, please.
Blood flow decrease in zone 1 but increase in zone 3,
Yes.
and ventilation decrease in zone 1, increase in zone 3, and
Hmm.
ventilation perfusion is increase in zone 1 but
Hmm.
decrease in zone 3, and partial
Hmm.
pressure of oxygen is increase in zone 1 but
Hmm.
decrease in zone 3, and carbon dioxide decrease in zone 1 but increase in zone 3, carbon dioxide,
Hmm.
partial pressure of
Hmm.
carbon dioxide.
Yes, this is how. And what about the VQ ratio in zone 1? Is it increase or decrease?
Zone, it is increase in zone 1
Hmm.
and but decrease in zone 3.
Yes, it is decrease in zone 3.
Zone 3.
Yes, very good.
Because oxygen exchange is more in zone 1.
Yes, because of this, yeah. So now what happens? Both the ventilation and the blood flow, they are non-uniformly distributed in the normal upright lung. Blood flow or perfusion, it is lowest at the apex and highest at the base because of the effect of gravity that you told me before. Now
Yes.
ventilation, it is lower at the apex and higher at the base because of the gravitational effects. Importantly, however, the regional difference for ventilation, they are not as great as the perfusion. Therefore, the ratio of VQ, it is higher at the apex of the lung and lower at the base of the lung. So at the apex, there will be higher VQ, oxygen will be highest, and carbon dioxide will be lowest. That is what you told me now, just the same diagram. That low blood flow, low low ventilation, but more VQ. Partial pressure of oxygen will be more, and carbon dioxide will be less.
Low.
Yeah,
Yes.
low. Or in zone 3, what will happen? The blood, there will be more blood flow, but when and ventilation will be more, blood VQ ratio will be less, oxygen will be less, but carbon dioxide will be more.
More.
Yes. Now you understood like how it goes from the zone 1 to zone 3?
Yes, ma'am.
Yeah.
But in zone 2, all everything is medium.
Yes. Zone 3 is the medium zone.
Then two second
Yes.
second zone is
Yeah,
medium zone.
second zone it is medium. Yeah, the blood flow is medium in that zone. Now VQ ratio in airway obstruction. So what happens in airway obstruction? If the airway they are completely blocked by a piece of stake which is caught in the trachea, so the ventilation it is zero. If the blood flow is normal, then VQ is zero. So
Yes.
obstruction means the VQ will be zero. This is called as shunt.
Yeah.
There will be no gas exchange in a lung that is perfused, but there is no ventilation. The level of oxygen and carbon dioxide of the pulmonary capillary blood will approach their value mixed their values in the mixed meaner blood. Therefore, there will be increase in AA gradient. That is the pressure of the gradient. It will increase in airway obstruction. So now you see here, this is the same diagram. Blood flow is lowest, blood flow is highest at the base. Ventilation is lower, but at the base it is higher. VQ, it is higher at the apex, but it is lower at the base of the
Yes.
lung. And the partial pressure of oxygen in the apex it is highest, while the carbon dioxide it is lower, but at the base it is the opposite. That is the oxygen is lower, but the carbon dioxide it is higher.
Higher.
But now what happens when there is, yeah. So what happens in cases of pulmonary embolism? That is when the lung is completely blocked. So the blood flow to the lung is zero. So if the ventilation is normal, then EQ will be infinite, and this is called as a dead space. There will be no gas exchange in a lung that is ventilated, but it is not perfused. So the partial pressure of oxygen and carbon dioxide of the alveolar gas, they will approach their values in the inspired air. So you understood now? Can you repeat
Yes.
for me in the
Yes,
VQ
ma'am.
ratio in airway obstruction?
In airway obstruction,
Yes.
if the airway is completely blocked, then the and blood flow is normal, then VQ will is zero, and this is which is called shunt. And in this
Hmm?
condition, there is no gas exchange in the lung, and that is perfused, but the lung receive blood, but no oxygen. Not they are not ventilated, and
Hmm?
partial pressure of oxygen and carbon dioxide of pulmonary capillary blood will approach their values in mixed venous blood. That the
Yes. Yeah.
oxygen will be low, and
Yes. Oxygen.
there is increase AA gradient means
That is
arterial
that.
artery.
Yeah. Yes. Yeah. There will be increase in the gradient.
Okay.
Okay. And what will happen when there's pulmonary embolism?
And pulmonary embolism, in this condition, blood flow to the lung is completely blocked, and
Hmm.
by the because emboli occlude the
Hmm.
pulmonary artery, and
Yes.
so the blood flow to the lung is almost zero at this in pulmonary embolism. And if ventilation is normal, that oxygen
Hmm.
is inside the lung, then ventilation perfusion is
Hmm.
infinite. That is which is called
Yes.
dead space,
Yes.
because
Called as dead space.
and no exchange in the exchange of gases will occur, and that is ventilated. There is oxygen but no perfusion.
No
Uh,
perfusion will be there. Hmm.
and so partial pressure of oxygen and carbon dioxide of alveolar gas will approach their value in inspired air. That
Yes.
same that like
Of the inspired air.
yes.
Yes. Now, how is the breathing controlled? So, breathing it is controlled by the brain stem. So, in
Mm,
breathing, we have two respiratory centers. That is the medullary respiratory center and the ventral. Sorry, we have the dorsal respiratory group and we have the ventral respiratory group. So, medulla is the it is located in the reticular formation. Now, this dorsal respiratory group it is responsible for the inspiration and it generates the basic rhythm for breathing. It receives input from the dorsal respiratory group, from the vagus and the glossopharyngeal, that is the ninth and the 10th cranial nerves, and output is from the dorsal respiratory group, which travels via the pharynx nerve to the diaphragm. So, and what is ventral respiratory group? It is responsible for expiration. It is not active during normal, quiet breathing when expiration is passive. It is activated, for example, during exercise. When the expiration, it becomes as an active
active process.
process. So you got that medulla, it has two groups, that is dorsal and ventral. Dorsal is for inspiration and ventral is for expiration.
Expired.
Yes. And we have another center which is called as the apneustic center. Apneustic center, it is located in the lower pons and it stimulates the inspiration, which is deep and the prolonged inspiratory gap. Now, what is nemotoxic center? It is located in the upper pons, while epinostic center it is located in the lower pons. Now, nemostatic center it inhibits inspiration, therefore it regulates the inspiratory volume and the respiratory rate. While cerebral cortex it is under the voluntary control, which is when a person is voluntary hyperventilating or hypoventilating.
So,
So a hypoventilation, it is limited by the increase in carbon dioxide and decrease in partial pressure of oxygen. So a previous period of hypoventilation, it increases the period of breath holding like this. So we studied now about the central control, and we have now the okay. So first you revise for me, summarize for me the central control of breathing.
central, central control of breathing
Hmm.
by the two groups of because central control is in the medullary
Hmm.
respiratory center is located
Hmm.
in the reticular formation of the medulla
Hmm.
of the brainstem,
Hmm.
and it has two groups, that is dorsal respiratory group and ventral respiratory group. And dorsal
Hmm.
respiratory group is primarily it is responsible for inspiration, and generate the basic rhythm of breathing. And dorsal
Hmm.
respiratory group mainly acts through the glossopharyngeal and vagus nerve, that are ninth and 10th cranial nerves. And these nerves relay information in the peripheral chemoreceptors
Hmm.
or and mechanoreceptors of the lungs. And they glossopharyngeal nerve relay formation in the peripheral chemoreceptors.
Hmm.
And output from the respiratory group travels via the phrenic nerve to the diaphragm.
Hmm.
And the ventral respiratory center mainly for the responsible for the expiration. And during normal quiet breathing is a passive process. And but in the active when the human is active and during exercise,
Hmm.
the expiration become active process. Normally it is a passive process,
Hmm. And what are the
expiration.
other centers?
Other centers are apneutic center, which is
Hmm.
located in the pons, lower pons,
Hmm.
and stimulates inspiration,
Hmm.
producing a deep or prolonged inspiratory gasp, and apneosis, yeah, or gasping, yeah,
Hmm.
or like
Yeah.
slow breathing.
Yes.
And a pneumotaxic center is located in the upper pons, which
Hmm.
inhibits respiration, and
Hmm.
therefore and it regulates the volume and respiratory center mainly. And the
Hmm.
cerebral cortex is the breathing, which can occur through under the voluntary control.
Hmm.
Uh, and a person normally hyperventilate or hypoventilate through the cerebral cortex.
Hmm.
In hyperventilation, breath holding is limited
Hmm.
by the so increase in partial pressure of oxygen, sorry, carbon dioxide. When breath
Yes.
holding occur,
Hmm.
then increase partial pressure of carbon dioxide and decrease partial pressure of oxygen.
Hmm.
Is a and previous and is a period of hyperventilation
Hmm.
extends the period of breath holding.
Yes. When there will be hyperventilation, so more will be holding.
Holding.
Hmm. Now, what are chemoreceptors? They are central chemoreceptors. Now, these central chemoreceptors, they are sensitive to the pH of the cerebrospinal fluid. When there will be decrease in the pH, so what will happen? There will be increase in the breathing rate. So decreased pH will cause increase in the breathing
Oh,
rate.
yes, ma'am.
Opposite.
Increase
So
pH,
high,
decrease, increase
increase
pH cause decrease breathing rate.
yes, increased pH will cause increased pH will cause decreased breathing rate. Very right. So what happens? The carbon dioxide it diffuses from the arterial blood into the cerebrospinal fluid because carbon dioxide it is lipid soluble molecule and it readily crosses the blood-brain barrier. In the cerebrospinal fluid, the carbon dioxide combines with water to produce hydrogen and bicarbonate. The resulting hydrogen ion it acts on directly on the central chemoreceptors. So, thus increasing in the carbon dioxide and the hydrogen ion, it stimulates breathing and it decreases the partial pressure of the carbon dioxide and it inhibits breathing. Resulting will be there will be hyperventilation or hypoventilation, resulting in carbon dioxide towards the normal. So we have chemoreceptors and we have the the control of central control of breathing.
Mm, chemoreceptors,
Now
central.
peripheral chemoreceptors they are located in the carotid and the aortic bodies, which is at the bifurcation of the common carotid arteries. Now, the aortic bodies they are located above and below the aortic arch. When there is decrease in arterial pressure of oxygen, so there will be increase in the breathing rate. And where there will be increase in the partial pressure of carbon dioxide, there will be increase in the breathing rate. And when there will be increase in the hydrogen ion, so what will happen? It is independent. It is directly independent of the changes in the level of carbon dioxide. So now you summarize it for me. What does the chemoreceptors mean? The central and the peripheral chemoreceptors.
Um, central chemoreceptors are in the
Red.
medulla.
Hmm.
of the brain
Hmm.
stem.
Yes.
They are sensitive to the pH of the blood and
Hmm. Yes.
cerebrospinal fluid. Decrease in pH
Hmm.
produce increased breathing, that is hyperventilation.
Yes.
And hydrogen ion cannot cross the blood-brain barrier, as well as carbon dioxide can cross the blood-brain barrier. So the carbon dioxide diffuses from the arterial blood into the cerebrospinal fluid, and carbon dioxide is a
Yes.
lipid is also lipid soluble, so it radially cross the blood-brain barrier
Hmm.
because it passes through the membrane.
And what about
And
peripheral chemoreceptors?
peripheral chemoreceptors, they are they are located in the
Brain barrier.
carotid
Yes.
bodies at the bifurcation of the common
Peripheral
carotid artery.
chemoreceptors.
When they are located in carotid body of the uh, at the bifurcation of common carotid arteries, and
So what about the
when
peripheral chemoreceptors?
uh, uh, they stimulate the peripheral stimulation, increase breathing rate when they are
Hmm.
stimulated,
Hmm.
and partial pressure of oxygen decrease
Decrease. Yes.
as low to at level of less than 60 millimeter of mercury before breathing is stimulated.
Hmm.
So when PO2 is less than 60 millimeter of mercury,
Hmm.
mm, the breathing is exclusively sensitive to partial pressure of oxygen.
Yes. So what happens in in peripheral chemoreceptors? The partial pressure of oxygen will decrease, pH will decrease, only carbon dioxide will increase.
Yes. So,
Hmm.
breathing will be stimulated.
Yes, then the breathing will be stimulated.
Stimulated.
Yes. Now, other type of receptors that we have, you just need to know the names of these receptors. There are other receptors, that is the lung stress receptors, the irritant
Mhm.
receptors, the juxtacapillary receptors, and the joint and the muscle receptors. They are
Okay.
also
Capillary and
the receptors that you should be knowing. So the lung receptors, they are located in the smooth muscles of the airways, and they are stimulated when there's this tension of the lungs. They produce a
Mhm.
reflex which is called as Brooks reflex. Now, irritant receptors, they are located between the airway epithelial cells. They are stimulated by noxious substances such as dust, pollen, smoking. They are stimulated. And these JS receptors, they are located in the alveolar walls close to the capillaries, and it will cause engorgement of the pulmonary capillaries, such as occur in condition like left side heart failure. And then we have the joint and the muscle receptors. They are activated during the movement of the limbs. That is, it is involved in early stimulation of breathing during the exercise. So now will you tell me about the other receptors of breathing? What are the names of other receptors?
lung stretch receptors
Hmm.
and irritant receptors and juxtacapillary receptors and joint and muscle receptors.
Yes, these are the four receptors
Four receptors. And
that
lung
occur.
stretch receptors located in the smooth muscles of the airways.
Hmm.
And when receptors are stimulated, this tension of the lung occur and
Hmm.
produce a reflect decrease in breathing
Hmm.
frequency. This
Yes.
is called hearing blur reflex.
Yes.
Hearing blur. And irritant receptors are
Hmm.
located between the airway epithelial cells,
Hmm.
and they are stimulated by noxious substances like dust and pollen.
Hmm.
And juxtacapillary receptors are located in the alveolar wall close to the capillaries, and
Hmm.
engorgement of pulmonary capillaries when
Hmm.
occur left heart failure stimulate these juxtacapillary receptors, and and then it causes rapid and shallow breathing.
Hmm.
And joint muscle receptors are activated during movement of limbs, are involved in early
Hmm.
stimulation of breathing during exercise.
Yes. So very good. These are the four other receptors apart from the central and the peripheral chemoreceptors. So now what happens when the person is doing an exercise? So there will be more increased oxygen consumption. There will be more production of carbon dioxide. There will be more ventilation rate because the person is breathing more when he's doing exercise. And but the arterial pressure of oxygen and carbon dioxide, there will be no change. The pH will also no change in moderate exercise. But when the patient is doing strenuous exercise, so the pH will decrease, such as causing lactic acidosis. And the carbon dioxide level will increase. The blood flow to the lungs, it will increase, and the VQ ratio, it will be more distributed when the patient when the person is doing exercise.
Doing exercise.
So you understood like how when the person is doing an exercise, what will happen? Yeah. So summarize for me.
Different
What will happen when the person is doing an exercise?
when doing exercise, the oxygen consumption increase, carbon dioxide production is
Hmm.
increased,
Hmm.
and ventilation
Hmm.
is increased, and
Hmm.
so oxygen consumption and increase, and carbon dioxide production is also increased, and arterial and partial pressure of oxygen and partial pressure of carbon dioxide, no change in it, and arterial pH is also not changed in moderate exercise, but
In- Yes.
decrease in strenuous exercise and produce lactic acidosis. And in
Hmm.
venous blood, partial pressure of carbon dioxide increase, and pulmonary blood flow, that is
Yes.
cardiac output, is increased, and ventilation perfusion
Hmm.
ratio more evenly distributed in lungs when person is doing exercise.
Yes. When the person is doing exercise, it will more increase.
More
And now what
equally
happens when the person?
equally distribute and increase
Yes,
also
it will be more. Yes, it will be increased and more equally distributed. But what happens when the person it moves to the high altitude? That is when the person is moving to the high mountain. So what happens? The alveolar partial pressure of oxygen, it is decreased. The partial pressure or the arterial partial pressure of oxygen, it is also decreased. There will be hypoxemia. The ventilation rate, it will increase, and there will be increase in the pH. So pH causes respiratory alkalosis, and
increase.
there will be hemoglobin. So increase erythropoietin 23 DGP DPG. It will be increased. Hemoglobin curve, it will be shift towards the right side, and the resistance in the pulmonary vessels, it is increased. That means there will be more hypoxic vasoconstriction in cases when the person moves to the high mountain. Resistance will increase. That is, there will be more constriction of the blood vessels.
Yes.
Yeah. So now summarize it for me that what will happen when the person moves to the high mountain area.
When person move to high altitude or high mountain,
Hmm.
then alveolar pressure of partial pressure of oxygen decrease,
Hmm.
and arterial PO2 also decrease.
Hmm.
So hypoxemic state occur, that is less oxygen in blood,
Yeah.
and
Exactly.
ventilation ventilation rate, that breathing is increased,
Hmm.
hyperventilation due to hypoxemia,
Hmm.
and arterial pH, that more due to hyperventilation, respiratory alkalosis occur,
Hmm. Yes.
and in hemoglobin concentration increase erythropoietin
Hmm.
formation and through kidney, and
Yes.
2-3 DPG concentration, that is diphosphoglycerol,
Yeah.
also increase, and
Hmm.
and oxyhemoglobin curve shift to the right and
Yes.
decrease affinity for oxygen,
Yeah.
and pulmonary vascular resistance also increase, that is hypoxic vasoconstriction.
Yes, hypoxic vasoconstriction, it also increases. So these three conditions you should be knowing. And what happens in pregnancy?
Pregnancy.
Yeah, oxygen demand, it increases by 20%. The airway
Mm.
resistance, it is decreased. There's increase in the tidal volume. The vital capacity, it is same. The respiratory rate, it is same. The forced expiratory volume, it is same. But TEFR, it is also same. The lung compliance is same, and but the chest compliance, that the chest can move up and down, or it can elasticity of the chest, it is decreased. This is what happens in uh, the residual volume. It decreases by 200 ml. There's decrease in the ERV, that is the that is the expiratory reserve volume. It is decreased. The normal expiratory reserve volume is 1500 ml, and the total lung volume also decreases by 200. Increase in inspiratory reserve volume. Partial pressure of the carbon dioxide is decreased to 30 millimeter, but oxygen partial pressure, it is increased, and the breathing is more diaphragmatic than the thoracic. And how does the oxygen consumption increases? Because the fetus will take oxygen, there will be increase in cardiac output, that is 6 ml per minute. The cardiac output will increase, and there will be increase in the renal work, that is 6 ml per minute, and the metabolic rate increases because the fetus is also there, so it becomes to 18 liter per minute. So you understood what will happen in case of respiratory change. Will you summarize it
Okay.
for us?
Respiratory changes in pregnancy.
Okay.
Oxygen demand is increased by
Yes.
20%, and airway resistance is decreased or increased tidal volume, and VC is ventilation.
Yes.
VC means
Vital capacity.
ventilation.
Vital.
uh,
Vital.
Vital capacity. Vital capacity remains same, and P and R are
Yes.
respiratory rate
Yes.
remains same, and FEV1 same, and PFR remains same, and lung compliance
Yes.
remains same and no change, and decrease chest compliance, and decrease um, RV residual volume is also decreased, that is 200 ml,
Hmm.
and expiratory reserve volume is decreased, and decreased total volume by 200. Total lung volume is also decreased by 200 ml, and increase inspiratory reserve volume, and decrease partial pressure of oxygen to 30 millimeter of mercury, and sorry, carbon dioxide. Decrease partial pressure of carbon dioxide to 30 millimeter,
Yes.
and partial pressure of oxygen is increased to
Hmm.
14 kPa and kappa, and breathing become more diaphragmatic than thoracic, and decrease in uh, distribution of maternal oxygen consumption in pregnancy, because fetus will consume 20 ml per minute,
Hmm.
and
And breathing
in
becomes.
and increase maternal metabolic rate, and that is 18 milliliter per minute, and renal
Hmm.
work is also increased, and that is 6 ml per minute. 6 ml.
6 ml per minute. Yes. So okay. So now take the question. Read the first question.
Uh, just now I will try, because
Hmm.
first
Yes. Yeah.
one
Yeah.
hour
You
I have
joined late
missed.
now. Yes. Yeah. Yeah. No problem. Just try.
Okay, you will help me.
Yes. Yes. Of course, I
And
will help you.
Which of the following lung volumes or capacities can be measured by spirometry? Functional
Hmm.
residual capacity, physiological dead space, residual volume, total lung capacity, and vital capacity.
Hmm.
Mm,
Yeah. Now guess it. Any
okay.
guess? What do you think?
First year MBBS knowledge. Recall because I have not read this.
No problem. No problem. Guess it. Whatever you, anything. What do you think will be the option?
Vit-
Any guess?
Vital
Yes. Yeah.
capacity.
Right. Yes. Very good. Yes. Vital capacity. It can be measured by the spirometry. All of them they cannot be measured by spirometry. Very good. So
Thank
okay.
you.
Now come to the second question.
Which volume remains in the lung after a tidal volume is expired?
Hmm.
And tidal volume, vital capacity, expiratory reserve volume, residual volume, functional residual capacity, inspiratory capacity, total lung capacity.
Hmm.
Mm.
So which
Mm,
remains?
Expiratory reserve volume,
Uh, Look,
no,
expiratory.
residual or
Yes,
residual volume,
functional residual
functional residual
capacity. Very
volume,
right. It
functional
is
residual
only the
capacity,
capacity which is remaining in the lungs
lung,
after the
functional
expired. Tidal volume is expired. So you
residual
take next
capacity.
question also.
Which volume remains in the lung after maximum expiration?
Hmm.
Tidal volume, vital capacity, expiratory reserve volume, residual volume, functional residual capacity, inspiratory total lung capacity. Uh, After maximum expiration. Residual volume.
Yes, excellent. Residual volume. It is always present in the lung. Very good.
Mm, like,
Now, yes. Now come to this question. Question number 3.
compare with the apex of the lung. The base of the lung has a higher pulmonary capillary PO2, mm, higher pulmonary capillary PCO2, high ventilation perforation ratio, and the same ventilation perforation ratio. Uh, VQ. C,
Hmm.
high ventilation perforation ratio. So it, it, ma'am, answer where I can I take some time for thinking. Base of the lung. Where is the acha, compare with the apex of the lung. The base of the lung has that picture you show tent type. Uh, I think base of the ma'am, can you please share screen? And
Yes, Fakra, I can't hear your voice.
Okay. Ma'am,
Yeah, what do you
compare,
think will be the answer?
compared with the apex of the lung, the base of the lung has mm, uh,
Hmm?
uh, a
It
higher
has what?
pulmonary PO2. No, PC,
Yes, carbon
carbon
dioxide.
dioxide,
Yes, it has
PCO2,
higher.
B,
Yes,
B,
but it will be this way. Oxygen will be low in the
low, low,
apex
low.
of the lung. Yes. Yeah.
It is more at,
So in the
it is
next,
maximum at the zone 1. VQ is more
yes,
at
zone
zone
one.
1.
Yes, it is more. And now this question,
Which of the
question number
following
20.
changes occur during strenuous exercise? Ventilation rate
Hmm.
and oxygen consumption increase to the same extent? No. Ventilation rate and oxygen consumption. And systemic arterial PCO2 decrease to about 70 millimeter of mercury. Systemic arterial PCO2 increase to about 60 millimeter. Systemic venous PCO2 decrease to about 20 millimeter. And pulmonary blood flow decrease at the expense of systemic blood flow. Ventilation rate and oxygen consumption increase. Mm, Now it's slightly confusing. Uh, During strenuous exercise, oxygen consumption is increased and carbon dioxide is also increased, and arterial PCO2 no change, venous PCO2, primary blood flow. Mm, Can you share screen?
Hello. Yes, Fakra, can you hear my voice?
Ma'am, can you share the screen? No, the MCQ. That was during exercise. Which changes occur?
Tell me. Hello. Hello.
Hello.
Fakra. Yes, are you able to hear me?
Yes, ma'am.
Yes, yes. Okay, okay.
Which of the following
Yeah.
changes
So
occur
tell me
during
what will.
strenuous exercise? Ventilation
Hmm.
rate and oxygen
Yes.
consumption increase to the same extent.
Hmm.
Mm,
Hmm.
Ma'am, I think
Oh, my
A
internet.
and systemic
Yes,
arterial
very good.
PCA.
A.
A is
Yes,
the
because it
answer.
increases to the. Yes, very good. A. And what will be the this?
Because oxygen consumption is also increased and carbon dioxide production is increased, which is share in table and during exercise.